So today I'm talking about frailty and sarcopenia in the elderly. And let's see. There we go. We'll just talk about the definition. How do we diagnose it? Frailty and sarcopenia. Why does it matter? Why do we need to diagnose it? Can we identify causes that contribute? Can we prevent, manage, and treat it? So those are kind of the things we're going to discuss. If you have questions, please speak up. Also, any comments and helpful tidbits, I want to hear it. So don't hesitate to speak up out there in the Zoom world. There's lots of definitions of frailty. I think most of us, you can kind of get a feel if somebody's frail, right? You can walk into a room and get a feel for a frail elderly individual. And what is it that we're actually getting a feeling of? I think all these definitions here kind of help explain what it is. Certainly loss of physical function, multimorbidity, clinical state in which there's an increase in an individual's vulnerability to developing negative health-related events when exposed to endogenous or exogenous stressors. So I think it's a lot of loss of hemostasis or the ability to deal with extra stressors. So you're kind of balancing, just hanging in there, and one little thing is going to tip you over the edge. So decline in function across multiple systems, loss of physical function, increased vulnerability to stressors, or decreased resilience. So all these things, I think, help define what frailty is. But like I said, I think most of us get a feel when we walk into a room, you kind of just get a feel for it. And I think when we get to walk into the room and get a feel for it, we're pretty severely frail. And so we want to try to get at these things a little bit earlier so that we can have, make a difference there and change the course of things. Frailty was originally defined back in the early 2000s by Freed. And this is how she defined it, right? A loss of 10 pounds unintentionally in the last year, a feeling of exhaustion. Everything I do is an effort. I couldn't get going. Slowness, so slow gait speed, low activity level and decreased energy expenditure, and weakness defined as grip strength back then. So since that time, there's been tons of studies done on frailty and lots of different ways to diagnose it. And we'll talk about some of those coming up. What are causes of frailty? Certainly there's no one cause of frailty. It is kind of a bunch of things coming together. Probably has a lot to do with inflammation as we age. There's been shown in studies to be high levels of IL-6 and CRP in a frail individual. It's a decrease in immune function, it's anemia, it's glucose intolerance, insulin resistance, low levels of DHEAS and IGF-1, increased cortisol, low testosterone, lots of nutritional derangements. The biggest one is, that we can act on, I think, is low protein intake. When they teach you back in medical school, they always taught us, and that's been a long time now, but tea and toast for the geriatric population, that's their diet. And it does pan out to be true when you really talk to your older folks about what they're eating. Often it doesn't involve a lot of protein for various reasons, whether it's a taste, whether it's putting the effort in to make a food, make a big meal, whether it's you can't chew because of dentures and teeth problems. So lots of reasons that we have a decline in protein intake. Other nutritional derangements, there's been shown to be decreased heart rate variability. So these aren't necessarily causes. I think what it boils down to is multiple chronic diseases coming together that lend person to become to have decreased appetite, to intake less, to move less, and then therefore lose muscle strength and decrease your metabolic rate, and then eat less, and the cycle continues, right? And that's kind of what these cycles of frailty depict, right? And it can be, I think there's often one inciting event. You know, they fall and break a hip, and they were kind of doing borderline pre-frail to not frail. And then because they broke their hip, they decreased their energy expenditure. They have these underlying chronic diseases. They become more malnourished. They lose their muscle mass. They decrease their resting metabolic rate. They decrease their power. They're more immobile. They're more impaired. They're falling. They have slow walking speed. They get weaker. They sit around more, and the whole cycle continues. This is just another kind of depiction of kind of how it's a cyclic and worsens because of its problems, right? You get decreased strength, increased exhaustion, you move more, you move less, you decrease your physical activity, and all those things get worse, right? So it's just a vicious cycle. And there's things happening at the cellular level that we talked about with poor insulin, more insulin resistance, more inflammation. So there's things happening at the cell level as well. Why does it matter? Because we have an aging population, because they cost more to the healthcare system. A frail person costs much more. They're more likely to die and have poor outcomes from surgeries, hospitalizations. They're people who need increased cares, home health at discharge, assisted livings, long-term care facilities. They're going to be in the hospital longer. They're utilizing a lot of walk-in clinic and ED visits. And again, poor tolerance to surgeries or chemotherapies and other treatments. And that's kind of where a lot of the research is right now in frailty. One of the big ones is in like oncology, surgery, and TAVRs, right? They've done several studies on pre-op frailty screens, and then how do those people do, and the people who score frail preoperatively do poorer with those kinds of surgeries. Makes sense. How can we assess frailty? There is a ton of screens out there that you can use for phenotypical frailty. A lot of the Edmonton, I think I have some coming up that I'll show you, but Frailty Index, the Edmonton Frailty Index, the Frail Scale, doing just simple walking speed or grip strength is a good way to measure for frailty. So we started in our clinic here, because one of the big things is catching people before they're frail or before they're falling. So we started doing gait speed on everybody 65 and older, in hopes that if they're starting to get slow, we make an intervention and avoid becoming frail. So I think, and we're starting in our resident clinic here in internal medicine, the similar thing on grip strength. So basically what we did is, if their walking speed, the cutoff for a good walking speed is kind of 1 meter per second. And so if they're slower than 1 meter per second, we kind of set up some just kind of markers. If they're 0.8 meter per second to 1 meter per second, we're prescribing exercise. If they're 0.6 to 0.8, we're prescribing physical therapy. And if they're less than that, then we're sending them to the multidisciplinary balance and stability clinic. And so these are interventions we're seeing, are we able to prevent their ongoing decline to frailty? We haven't gone back to look to see if we made a difference, but we're hoping so. And we're going to do a similar thing, like I said, for grip strength. So I think the other thing we're trying to do, I think, to prevent frailty is have physical therapists in the clinic, in the primary care clinics with the clinicians. And so on Tuesdays and Thursdays, we've piloted it where we have PT who's around. And the idea for this one is, I think a lot of frailty happens when our older adult population has hip pain or back pain or knee pain, and so they stop moving. and sit more, and then their cycle continues, right? So here, if they're complaining of that, we introduce them right away. Oh, here's a physical therapist who can see you today, just to see if that gets them in the door to be more likely to follow up with their physical therapy or exercise specialist. So different things we're trying here to kind of intervene in this process and to make a difference. I think in hospitals, a lot of hospitals for acute care, to try to avoid people teetering into frailty if they came in more robust, and certainly hospitalizations are a big place to become frail, right? And so there's the help programs, and increasing mobility is a big push in hospitals, and instead of the back in 20 30 years ago when we'd lay them down and have their bed alarm on there and not move them at all. So hopefully all the places that you guys are at, we're getting people up and moving very regularly out of their bed to eat their meals. All those kinds of things are important to prevent frailty in the hospital. So here's the frail scale. St. Louis University's geriatric department has this frail scale, and you can access it on their website. I think it's a good, easy one to use. I'm kind of using it preoperatively. Most of the pre-op, it's a validated tool for frailty, and it's pretty easy, right? It's a few questions. Are you fatigued? So getting at the energy level. Can you walk up a flight of stairs? Can you walk a block? Do you have more than 5 illnesses? And have you lost weight? So they have made it on a scale. So if you have 3 or more positive answers, then you are frail. If you have 1 or 2, you're pre-frail. And if you have 0, then you're considered robust, right? So I think the big thing is, if you are pre-frail or frail, then we can probably make a difference and turn you around if we do some things, and we'll talk about those later. But if you're, severely frail, the highest numbers you can get here, then a lot of times we can't reverse that, and we should think more along the lines of palliative care, hospice. Here's the Edmonton Frailty Scale. So it has a lot more questions that go into what are you doing with your ADLs? How do you consider your general health? Sorry, the phone's ringing. Cognition is part of at play here. Nutrition they add in, mood, continence. So they add a few more things in there to help give a picture of frailty. And there's been several more studies on kind of isolation and loneliness and its contribution to frailty. So the more isolated and alone you are, or there's lots of loneliness scales. If you screen high in loneliness, you're more likely to have frail or to become frail at some point. And I think if you go back, there's lots of studies on life space out there. So the amount that you get out of your home, so the more that you stick to your home, right, the more frail you're likely to be, the more lonely you're likely to be, the less interaction you have, the more chronic diseases you probably have, right? So life space matters too. Although you can have interventions to keep you in one space, but still have the things of a large life space. I think like assisted living facilities, right, where you have the activities and things coming to you. But I think there's a lot more studies on loneliness contribution, life space contribution to its effect in contributing to frailty. Kind of switching gears here a little bit, sarcopenia, right, which is a fancy term for muscle weakness or decreased power. It's age-related decline in skeletal muscle mass concomitant with decreased strength and or function. You can measure it by gait speed, by hand grip strength, by squat strength, all those kinds of things. But sarcopenia is associated with decreased quality of life, falls, frailty, disability, and mortality, like frailty. it also has a very strong association with osteoporosis and fractures. So if you have two people with the same bone density in the osteoporotic range, the weak person is likely to fracture, much more likely to fracture than the strong person who's doing weight building, right? So if you're frail, you have sarcopenia, but you don't necessarily have frailty if you have sarcopenia. So sarcopenia is the slow walking speed and muscle weakness. Frailty is that plus the weight loss, fatigue, and low physical activity. Causes of sarcopenia, right, are aging, decreased levels of DHEA, IGF-1, testosterone. We get higher inflammatory markers as we age, so those are the increased cytokines. We're moving less, decreased physical activity. You're eating less, especially protein, like we talked about before. We have decreased neuronal motoring units per muscle unit. We have decreased vascular supply. So all of those things, I don't know about the small birth weight thing in there, but I guess it's associated with sarcopenia later in life as well. So that's kind of sarcopenia. Same risk factors, right? If you're older, you have multiple chronic diseases, you're more sedentary, you're not eating well, you have bed rest from a hospitalization, then you have decreased buildup of your muscles. After injury, inflammation, the oxidative stress, the decrease in mitochondrial function, then you have increased breakdown of muscle. There's also different kind of scales to how to diagnose sarcopenia. And there's also St. Louis University has the SARC-F, which has been validated as a tool to help identify somebody who might have sarcopenia. And that just asks questions of the patient about strength. How difficult is it for you to carry 10 pounds? How difficult is it to cross a room? How much difficulty do you have transferring from a chair or bed? How difficult is it climbing a flight of 10 stairs? How many times have you fallen in the past year? And so obviously, you're doing best if you have 0 points, and you're doing worst if you have the highest points. So greater than 4 on the scale means you have sarcopenia, likely. So different tools to have in the back of your mind when you're trying to diagnose frailty. Or like I said, I think the whole point is to try to get people who are at risk for frailty and have some intervention before they're frail or severely frail, for sure. So what can we do when we see a pre-frail person or a frail person? There's been studies done that show that a Mediterranean diet that is high in protein can improve frailty. I think protein is the key a lot to this, because and the anti-inflammatory diet, which is a Mediterranean diet as well. So, but protein is a big part of it. Giving an exercise prescription that includes strength and resistance, in addition to the aerobics. Getting rid of polypharmacy. So polypharmacy in our older adult population is huge. Polypharmacy is 6 drugs or more is the definition. And I mean, most of our older adults with multiple medical problems have, I mean, upwards of 15, 20 meds on board, right? So if we can reduce that, often we can improve upon frailty. And I think, you know, if you happen to have some geriatrics specialty people around who can do a multidisciplinary approach for a comprehensive geriatric assessment, I think that is helpful. And I think the people who shouldn't be involved in that, you know, are a geriatrician or somebody who is passionate about the older adults, who's done some studies in geriatrics. They don't have to be a fellow, a board certified geriatrician, but an internist or a family practice doctor who simply has an interest, and so has done some look into things that are going on in this population, along with physical therapists, social worker, pharmacist, are all good people to have involved to help with the geriatric assessment. But certainly those groups, what they may do together is give exercise prescriptions, decrease polypharmacy, or get rid of medications that could be contributing to frailty. I think it's probably good to have a dietitian. I haven't been able to get one on board, although I keep asking and trying, but to help with the diet suggestions that we're making. But the biggest thing is preventing immobility, right? So we want to treat any reversible or precipitating things that could come up. So if it's, knee arthritis that is limiting them from moving and they're still robust, I think you fix I always say, if you're starting to limit your activities because of your knee pain and the, steroid injection is not helping you continue to do that, then it's time to do the surgery. Don't wait till you've been sitting around for 2 years and then decide to get your knee done, right? Because then you're more likely to be frail and have poor outcomes because of the frailty. So I think doing all the things early on to keep people moving. And that's hard because a lot of people who end up frail are people who are never exercisers in the first place. And while they will benefit the most than somebody who's exercised always, they're the hardest to motivate into doing this, I would say. So if anybody is out there who's learned the motivational tricks to get these people to exercise, I think, the biggest successes I have had is if you can cling on to what matters most to them. And it's something like, playing with my grandkids, right? Then you can usually motivate around those goals of what matters to them. So that's what I try to do. But if anybody has any good ideas, I'm happy to have you share them with the group. The other big thing, right, is to minimize things that can disrupt their balance, right? So try not to get sick. How do we prevent them from falling and breaking something? So treating their osteoporosis. If they're stressed and lonely and isolated, how do we get them supports in place? Should they move to an assisted living where they have built-in social life and all the activities that increase their life space or decrease their loneliness, right? Treat their depression so that they can get out and get active. So we got to do all those things. And I think prevention is the key here, right? If we could prevent it, we'd be the most successful. And so basically that's eating healthy, exercising, and staying out of the hospital, and being active and using your mind and having a social life and a purpose and engaging with people. So all the things if you've ever read The Blue Zones or seen the documentary about the Blue Zones, that's the National Geographic went into the places where people were living the longest and the healthiest. And so there's 7 places around the world that there was a big population of people living into their hundreds. Loma Linda, California was the one in the United States, and it's a Seventh-day Adventist community. So they're, I think they have a lot of social connection, and they are exercisers and they are vegetarian. So let's see, where else? Santorini is one. Somewhere in Costa Rica was one. So a lot of Mediterranean type diets with lots of plant proteins, less red meats, less inflammatory foods, and more active lifestyle. Okinawa, Japan was one. So interesting book and documentary if you ever want to look it up. But it talks a lot about community, respect for their elders, how they de-stress. But all those things I think play a part. And so how can we help work on the depression, isolation, loneliness, in addition to the mobility and polypharmacy and multiple health conditions, right? So we got to treat all those things as well. Let's see, like I said, prevention, physical activity, Mediterranean diet, protein. Probably the one thing I repeat in almost every visit I have is more protein in your diet. Because like I said, if you really do talk and say, what do you have for breakfast? What do you have for lunch? What do you have for dinner? Very little protein. So I talk a lot about how much protein is in foods, what are alternatives to meat that we can get you to eat. Snacking all day really becomes a job because, you know, for somebody who's older than, I don't know, probably 50, 40, you need 1.5 grams per kilogram in a day of protein in your diet to maintain your muscles. That's a lot, right? For these old folks who aren't getting nearly that. So it becomes their job. I tell them to eat protein, and we give them a list of, you know, this is how much protein is in your average size chicken breast, and this is how much protein's in an egg and yogurt, cottage, you know, try to get them to get those in throughout the day. But then once they have the protein, right, they have to do the exercise to build the muscle. And so there have been tons of studies on other supplements. You know, testosterone obviously builds muscle, but it has side effects that are not good for this age group. DHEA, it's not been proven to be beneficial. If they have a vitamin D deficiency, yes, we should be correcting that. And there's maybe been some evidence for these things, leucine, beta hydroxy, beta methylbutyrate. So, I mean, I think that's still a place that probably needs to be studied. Creatine, you know, is that helpful, harmful? Kidney function probably, but it's, yeah, you know, all those things we aren't 100% sure of, but for sure protein. Do they have B12 deficiency? I think is always a good thing to look up because that contributes to weakness balance problems that would, and is very common as an older adult to have B12 deficiency. So all those kinds of things we know for sure can improve upon their sarcopenia and frailty. Like I said before, I mean, I think if you're severely frail, it's really hard to reverse. Certainly the things we talked about worth a try, but it's really hard to reverse severe frailty. And then we need to be thinking more about, is palliative care, hospice the route to go for you? We certainly should be avoiding surgery, you know, aggressive surgeries and things at that point because the outcomes are likely to be pretty poor. So I got a little bit of a patient case here we can talk about and kind of work through. It's a little vague, but I think we can make something from it. So an 80-year-old woman is admitted to the hospital for treatment of uncontrolled hypertension. She has long-standing fatigue and poor energy. She has lung disease, heart failure, aortic stenosis. She's had worsening of her aortic stenosis, and she's lost weight in the last year. When you examine her or she's seen in the hospital, her blood pressure is a little bit elevated. She has a BMI of 18, heart rate of 63, but it's really hard. She has to take multiple attempts to get out of the chair, and she has a slow gait speed. So based on this, Does she have frailty or sarcopenia? I think we can say yes, we're leaning toward that, right? Where she's losing weight, she's fatigued, she has poor energy, she has multiple chronic diseases, it looks like. So I think we're trying to say yes, she's a frail person. Does she have sarcopenia? Pretty much we can say so by the multiple attempts to get up out of the chair, that she probably fits both sarcopenia and frailty. So how does this change how you're treating a person in the hospital and your discharge plan, right? I think you all know, she's there. Should we get them up more? I think we should be really concentrating on not letting them lie in the bed. They should be out of their bed for meals. We should be, I mean, I know resources are probably the limiting thing, but we should be getting her up, moving her much more often, because, you know, one day in bed is going to have a huge consequence for her. So I think we need to have PT involved, have volunteers involved, keep her moving while she's in the hospital. And then treatment plan, right? She's going to need at the least probably home health, versus will she need to go to transitional care, and that kind of thing. But we know that there's going to need support for strengthening on discharge. And then she has this aortic stenosis, and so cardiology comes in and says she needs a TAVR. And no offense to cardiology, but they will tell this person, I've had this so many times, that if they don't get a TAVR, they'll die suddenly. And so that's the reason to get the TAVR. And I think personally that if this person, so I have, you know, an 80-year-old who's still working a construction job, who had aortic stenosis, who is starting to get dizzy and lightheaded and more out of breath and fatigued at his job. And so he's a perfect person to get a TAVR or his aortic valve replaced. Contrary to the patient who is the same 80-year-old but sits at home, and what matters to him the most is to sit and watch his, you know, baseball team play on TV, and he never gets dizzy or lightheaded, and he doesn't have shortness of breath doing what he loves to do. So he basically has no symptoms of his aortic stenosis. He probably would if he tried to push those things, right? But he doesn't want to. And he's content and loves his life with what he's doing. He's probably one who I would say does not need to go through a TAVR, because we'll probably have a worse outcome at the end of life. So that's kind of my spiel on what does she need a TAVR, right? I think it's based more, you can put frailty in there, right? And that will sway you one way or another. But I think what it comes down to is what matters to the patient. Are they having symptoms that we think the TAVR is going to fix to help them do what they want to do and improve their quality of life? What if they had horrible knee osteoarthritis and wanted a total knee or a total hip done? And I think that's the same thing. If they're frail or severely frail, you're likely to have poorer outcomes. But so I think the time to do the knee surgery was before she became frail, because her knee hurt, right? So bad that she stopped doing activity. So sometimes I think we need to intervene a lot earlier than we are to prevent the frailty from happening. Now, could we get her exercise into a point where she's less frail and is more likely to do better? I think so. So I think that one's quality of life, right? If the horrible knee pain is affecting her sleeping, then maybe it's more worth doing. So I think it's important to make those decisions not only on frailty and heart condition and all those things, but also on what matters to them and what's their quality of life like. Certainly, you don't want to be intubating somebody with severe aortic insufficiency. you would want to do spinal anesthesia probably at that point if you were going to go for the total knee.